Hello guys, let's talk about macrocytic anemia. We'll talk about B12 deficiency, folate deficiency, and we will talk about how to make diagnosis of B12 deficiency, how to make diagnosis of folate deficiency. We'll do two questions in next couple of minutes. I have a question number one. A 70-year-old woman, she comes to your office with a chief complaint of unsteadiness and numbness. You do workup, her white cell count is 4000, her hemoglobin is slightly low, it is 11, her platelet count is normal, her MCV is slightly high, 102, and her complete metabolic profile is normal, her sodium, potassium, calcium, liver function, kidney function, blood glucose is normal. So you are suspecting this patient have slight macrocytic anemia and you check her vitamin B12 level. Her vitamin B12 level is 230. Normal range is between 200 to 900. You also check her folate level, it is 4. Normal range is 2 to 20. Which of the following is the most appropriate next step in the management of this patient? Option A, methylmalonic acid level. Option B, vitamin B12 supplementation. Option C, antibodies to intrinsic factor. Option D, folic acid supplementation. So here the right answer is option A. We will check her methylmalonic acid level. This patient most likely have vitamin B12 deficiency based on her symptom because she has unsteadiness, numbness, and she has slight macrocytic anemia. However, checking B12 level has low sensitivity and specificity to diagnose B12 deficiency. So in order to confirm the diagnosis, the best step is option A. And we would not give her B12 supplementation at this point or folic acid supplementation because we don't know the diagnosis because her folate level is also borderline low. Now, antibodies to intrinsic factor, we check if patient have evidence of pernicious anemia, which happen if patient have autoimmune disorder and patient who have a GI symptom. This patient do not have any history of autoimmune symptoms. She does not have any GI symptoms, so we don't check intrinsic factor antibodies. And we check intrinsic factor antibody once you have confirmed the deficiency of B12 and once you have confirmed pernicious anemia. So let's talk about why did we pick option A in this patient. So in human cell, B12 is required for two enzyme reactions. The first reaction is methylmalonic acid is converted into succinyl coenzyme A. You need B12 as a cofactor. Now this reaction is very important for myelin synthesis. So if patient have B12 deficiency, they can have CNS symptom, they can have reversible dementia because of this reaction. The second reaction is conversion of homocysteine to methionine. This step also required B12 as a cofactor. This step also required folate. Now this reaction is very important for hematopoiesis. So if you have deficiency of B12 and folate, patient can have ineffective hematopoiesis which can cause megaloblastic anemia, pancytopenia. Now let's say if patient have a deficiency of B12 level, they will have elevation of methylmalonic acid plus they will have elevation of homocysteine, and that's why we check methylmalonic acid level in our patient. Now our patient had slight macrocytic anemia. Patient who have B12 deficiency who are older, more than 60-65, they can have neuropsychiatric symptom without megaloblastic anemia. So you might not see macrocytosis, you might not see hypersegmented neutrophil, you might not see pancytopenia. That happens because of this reaction, because folate and B12 are required for DNA maturation, and if because of ineffective erythropoiesis, these patients can have macrocytic anemia. So our patient only had a neuropsychiatric symptom and which can be seen in older patient. So let's talk about vitamin B12 levels. So if vitamin B12 level is less than 150, you have a diagnosis of B12. You might not have to check you might not have to do further investigation. So if B12 level is less than 150, you can replace it. You can look for the causes. The most common cause is nutritional deficiency. The second common cause is rule out malabsorption, and third is intrinsic factor antibodies. Thus, if B12 level is between 150 to 300, this has a low sensitivity and specificity for diagnosis of B12 deficiency. So here you can check methylmalonic acid level. If the level is more than 300, most of the time they are normal, so no further testing is required. However, in real practice, we like to keep level more than 400, so you have to keep that thing in mind. So let's talk about folate deficiency. If patient have folate deficiency, it affect only this reaction, and patient will have only elevation of homocysteine. So folate deficiency can happen because of diet, alcohol, or small bowel disease. B12 deficiency take years to develop, but folate deficiency can happen in weeks to months, okay? And in US, the most common cause of folate deficiency is alcohol abuse and small bowel disease. And folate blood level, they vary a lot. If you take a single meal of high folate, you can have variation in the level. So folate level are not accurate if you are trying to make diagnosis of folic acid deficiency. So let's do question number 2. You have a young female, 30-year-old female. She was found to have macrocytic anemia. Her white cell count was 4,000. Her hemoglobin is 9. Her platelet count is 200,000. Her CMP, complete metabolic profile, is normal. She has a past medical history of hypothyroidism, and she also has a past medical history of type 1 diabetes mellitus. Her B12 level is 80. Her folate level is 15. Which of the following is the most appropriate next step in the management? Option A, methylmalonic acid level. Option B, homocysteine level. Option C, bone marrow aspiration. Option D, antibodies to intrinsic factor. Here the right answer is option D. This patient have pernicious anemia. Now pernicious anemia is seen in patients who have autoimmune disorder. This patient have hypothyroidism and type 1 diabetes mellitus, and patient who have hypothyroidism, type 1 diabetes mellitus, they can have pernicious anemia, they can have antibodies to intrinsic factor. Now why we did not check methylmalonic acid level in this patient? Because this patient B12 level is very low. It's almost 80. So you have confirmed the diagnosis. You don't have to check homocysteine level or methylmalonic acid level. What about bone marrow aspiration? The option C. Now patient who have pernicious anemia or megaloblastic anemia secondary to B12 or folate deficiency, they can also have pancytopenia. So sometime it can misguide you. So bone marrow aspiration is usually not required, but if you do bone marrow aspiration, it can mislead you. These patients can have abnormal bone marrow finding. So bone marrow aspiration is not recommended once you have confirmed the diagnosis of B12 and folate deficiency, until unless you are suspecting patient have underlying myelodysplastic syndrome. So let's talk about why did we check intrinsic factor antibodies. So we have a R binder in our saliva which bind with B12 in the stomach. So we have parietal cell in the stomach which produce intrinsic factor, and pancreatic lipase cleave the R binder from B12 in the duodenum, and in the small intestine, intrinsic factor and B12 bind with each other, and this complex goes to ileum. From ileum it is absorbed in the portal circulation, and it goes into the liver. So this is the normal B12 metabolism. Intrinsic factor play an important role. If you have antibodies against intrinsic factor, you can have vitamin B12 malabsorption. That's what was happening in our patient. So let's talk about pernicious anemia. It is characterized by destruction of gastric mucosa and parietal cell, and on top of that, these patients have intrinsic antibodies against intrinsic factor. Most of the time pernicious anemia is seen with additional autoimmune condition, typically seen in patients who have type 1 diabetes mellitus, hypothyroidism, celiac disease, or polyglandular syndrome. Now, one important point, pernicious anemia is also associated with autoimmune metaplastic atrophic gastritis, which is a precancerous condition. It can lead to GI cancer. So recommendation is, if you have made diagnosis of pernicious anemia in a patient, you should do one-time upper GI endoscopy. So let's talk about treatment of vitamin B12 deficiency and folate deficiency. Now, vitamin B12 deficiency can be treated with oral B12 supplementation. The reason is our daily requirement of B12 is 2 to 3 microgram per day. If you give patient very high dose, 1000 to 2000 microgram, that is more than sufficient. Even if they have malabsorption, even if they have antibody, they can still absorb very high dose. And B12 deficiency happen in years as compared to folate deficiency, which happens in weeks or months. Now, one exception, if patient who have neuropsychiatric symptom, who have significant megaloblastic anemia, if they have B12 deficiency, you can treat them with parenteral B12. So you can give them 1000 microgram per week for a month, and after that you can give them monthly shots. On the other hand, folate deficiency can be easily treated with oral supplementation. You can give them 1 to 5 microgram daily. Our daily folate requirement is 100 to 200 microgram. So if you give them 1 to 5 milligram, that is more than sufficient. Now with this, we are done with B12 and folate deficiency, anemia and megaloblastic anemia. We will talk about normocytic anemia and hemolytic anemia in next couple of minutes. So I'm going to stop it here. Thank you.